So first, let's define what osteoporosis means. So osteoporosis is defined as a skeletal disorder characterized by compromised bone strength that predisposes a person for fracture. So osteoporosis is typically considered a silent disease. And what this means is that most patients don't even know they have osteoporosis because there's usually no symptoms associated with it until you have a fracture. Fractures can occur in almost any bone, but the most common locations are usually the vertebrae of the spine, the arm, or the hips. Osteoporosis can affect both men and women, although it's more common in women, and can also occur in any age, but the risk does increase with age, and we see it most commonly in postmenopausal women. So here on the screen, we have a picture of bone biopsies of what a normal healthy bone looks like and what an osteoporotic bone looks like. As you can see here, the normal bone has thick structures and plates that connect between the bone, whereas the osteoporotic bone has definitely lost definition and mass, and some of these rods are not even completely connected, and that's what increases the risk for fracture. So why is osteoporosis important? So the lifetime risk of any fracture occurring in a woman from the age of 50 years and older is about 40%. So that's pretty significant risk. And there are about 2 million osteoporotic fractures that occur in the United States per year. The most common location for fracture is the vertebral spine. And having a vertebral fracture can basically increase risk for mortality or death in patients, but it can also increase risk for having recurrent fractures and other fractures in the future. And what's interesting to note is sometimes vertebral fractures can not have even present with any symptoms. So some patients don't even know they have a vertebral fracture because it can be painless in some instances. However, although there are consequences to osteoporosis, it is preventable and treatable. However, unfortunately, most men and women are not being screened or treated when they do fracture, or if they do have underlying osteoporosis. So it's definitely a public health issue. So who is at risk for the development of osteoporosis? There are definitely some underlying factors that can predispose a patient to developing osteoporosis in the future. So sex is one of them. Women are more likely to get osteoporosis than men, particularly postmenopausal women, because estrogen is actually protective for the bone. So after menopause, having that estrogen deficiency can increase the risk for osteoporosis. Older age is also a risk factor, which is why we usually start screening after age 65. Patients who have a small body size or are thin or frail have a higher risk of osteoporosis because these patients may have not achieved their peak bone density mass. In terms of race, we find that patients who are white or Asian tend to have a higher rate or incidence of osteoporosis than women who are African American or Mexican American. In terms of family history, this is also very significant because if a patient has a parent that had osteoporosis, or specifically a parent that had osteoporosis with a hip fracture, that can also increase your risk for developing osteoporosis in the future. In terms of diet, not getting enough calcium in the diet or vitamin D can also predispose you to developing decreased bone mass density and osteoporosis. And patients who are malnourished or have malnutrition, anorexia, again, you're not getting the nutrients that you need to maintain a healthy bone, and that can also increase the risk. There are other medical conditions that are associated with increasing the risk, specifically conditions that can cause inflammation. Patients with rheumatoid arthritis have much higher rates of osteoporosis than other patients. Other predisposing conditions can include disorders like epilepsy, where patients are taking anti-epileptic medications that can also increase the risk. And cancer treatments can also increase the risk as well. And then lastly, lifestyle factors. So patients who have a history of smoking or alcohol misuse also have higher rates of osteoporosis than the general population. So who should be screened for osteoporosis? So we usually diagnose osteoporosis based on routine screening, and patients are assessed for this using something called a DEXA scan, which is basically an X-ray that calculates your bone density or how strong the bone is. And part of this calculation is something called the T-score. So what the T-score is, it's basically a comparison of your bone mass density compared to a healthy 30-year-old individual who has achieved their peak bone mass density and is healthy. So it's comparing your bone to that of a healthy patient. The patients who are recommended to be screened and to undergo this bone density DEXA scan are women who are older than 65, or postmenopausal women who are under 65 but have those risk factors that we just discussed. Adults with fragility fractures are also recommended to get screening. And basically, to define a fragility fracture, that's defined as any fracture that occurs from a fall from a standing position or standing height. So if you fracture while you're standing or you're sitting, that's considered a fragility fracture, and you should have a bone density scan done. Other people who should be screened are adults that have diseases that are associated with increased risk for osteoporosis, like rheumatoid arthritis or cancer. And then in terms of men, men can be screened starting at age 70, or if they meet any of the other criteria as discussed. How do we make the diagnosis once we've completed the bone density scan? So again, we look at the T-score, which compares your bone mass density to a healthy 30-year-old patient. And osteoporosis is defined as having a score that's less than -2.5. The other way we make the osteoporosis diagnosis is if a patient has had, again, a fragility fracture, so fracture from a fall at a sitting or standing position. Aside from osteoporosis, there's another diagnosis called osteopenia, which is decreased bone mass density that can, over time, if not treated, become osteoporosis. And again, we look at the T-score to help us with this diagnosis. And the T-score results are between -1 and -2.4, and that's considered osteopenia. Not everyone with osteopenia may be a candidate for treatment for osteoporosis, but some patients may be candidates. And the way we figure out who may benefit from treatment in the setting of osteopenia is we calculate something called the FRAX score. And what the FRAX score does, it creates a probability, an estimate of how likely are you to fracture in the next 10 years. If the likelihood for fracture is high, then at that point, we also recommend treatment for osteopenia to make sure that we prevent it from progressing into osteoporosis. In terms of the medical evaluation, so after we've diagnosed osteoporosis based on DEXA or based on the history of fragility fracture, it's important to rule out other causes. There could be other conditions that can increase the risk of development of osteoporosis. So it's important for us to rule out if you have any of those underlying conditions. So first, we'll do a history and physical examination, and we'll also do blood work. So we'll check calcium levels, vitamin D levels, phosphorus, which are all work in unison together to help to maintain strong, healthy bones. We also check other hormones that may be associated with the development of osteoporosis, like parathyroid hormone, which Dr. Smith will go into more in her talk, thyroid function tests. And I also recommend doing a 24-hour urinary calcium test. And this test is important because it tells us if you're losing too much calcium in your urine, or it tells us if you're not getting enough calcium in your diet or from supplements and you need to be repleted. So definitely recommend doing the urine study in the setting of osteoporosis. The other thing that we can check are bone markers. So basically, bone markers can tell us, are you actively breaking down bone or if you're actively building bone? And that's an easy test that's done via a blood draw. Other labs may be indicated depending on your history, but that's the general start of the workup. In some patients, particularly patients who are over 75, patients who have something called kyphosis or curvature of the spine, like this picture shows here, patients who have had or noted loss in their height. So if you've lost 1.5 centimeters in your height, then if you meet those criteria, then we would also recommend doing an X-ray of the spine to rule out a vertebral fracture. Because again, some patients may have vertebral fractures and not even know it because sometimes it can be painless. So in those settings, we do also get an X-ray of the spine to make sure that there is no underlying fracture that we're not aware of. So after doing the workup, the evaluation, next comes treatment. So the first mainstay of treatment is making lifestyle changes. So if a patient has a smoking history, I'm advising them to quit. Or a patient has a history of alcohol misuse or abuse, advising them to cut back and stop. In terms of calcium supplementation, so calcium and vitamin D are both very important in maintaining bone health. The recommendation is to make sure that you're getting at least 1,200 milligrams of calcium per day. And that could be calcium from the diet or calcium in a supplement form. And in terms of vitamin D, the recommendation is to get at least 800 to 1,000 international units of vitamin D per day to maintain vitamin D levels at goal, which is basically a goal of having your levels above 30 for vitamin D. And supplementation with both vitamin D and calcium has been associated with reduced risk of hip fracture. So it definitely can help. And here I have included this chart of different foods and that contain calcium, just to give you an idea. So roughly 3 to 4 servings of these calcium containing products will get you to the 1,200 milligram goal. So for example, milk can be skim, 2% whole, it's about 300 milligrams of calcium. Orange juice is a good amount, has a good amount of calcium as well. Tofu is great. And other things like beans, almonds, leafy green vegetables, sardines. These are all products that have a good amount of calcium that can help reach your goal of the 1,200 milligrams per day. However, in patients that are having difficulty meeting that goal, if you're not a big dairy eater and you're not reaching your 1,200 milligram goal per day, then at that point we would recommend starting you on supplementation. However, do note that supplements may sometimes be associated with a higher risk for kidney stones. So if you are able to get it from the diet, that's preferred. So there are 2 main types of calcium that are on the market that you can get over the counter. The first class, it's called calcium carbonate. And with calcium carbonate tablets, you get 40% of elemental calcium, meaning that whatever is listed on the bottle, you're only absorbing 40% of that amount. Calcium carbonate is relatively affordable. Tums, the antacid, actually is pure calcium carbonate. And what's important to note is if you are taking calcium carbonate, make sure that you are taking it with a meal. So take it with breakfast or take it with dinner because it requires acid for it to be absorbed. So that's important. Patients who are taking proton pump inhibitors like omeprazole or Pepcid, these medications decrease the amount of acid that you have in your stomach, so you may not be getting the full amount that's stated. So that's just important to note. The other type of calcium supplement available is calcium citrate. And this medication is 20% elemental calcium. So you're getting 20% of the amount of calcium that's listed on the bottle. It tends to be a little bit more expensive than the calcium carbonate. However, you do not need food or acid in order to absorb this medicine. So it may be better for patients who are on the proton pump inhibitors or the Pepcid. Aside from the vitamin D, the calcium, there are other lifestyle changes that can also be enacted. One of these, the key is I want to make sure that you avoid any over-the-counter strontium supplements. So strontium looks very, very similar to calcium. So it'll go into the bone and it'll replace calcium in the bone. And because it's a heavier molecule than calcium, the next time you go get your bone density scan, it may falsely make it look better. So your bone density scan may look like it's improved while on the strontium when it really has not. So it's a false improvement. So I recommend staying away from strontium because of that false positive improvement. So aside from that, other changes that can be made. So definitely participation in regular weight-bearing exercise, resistance training, walking counts. Anytime you're putting weight on the bone, that's actually helping to help build backbone and keep it stable. So definitely recommend walking routinely and exercising when you can. However, the one thing I would caution for patients who have osteoporosis of the spine is that if you are exercising, which we encourage, making sure that you're not doing any kind of twisting motion or doing bending at the hip with heavy lifting, because those two maneuvers can actually increase the risk for spinal fractures. So please try to avoid twisting motions and bending in the setting of spine osteoporosis, since we want to make sure that we're preventing those fractures. Other things that would be recommended would be balance training. So making sure that you feel strong and steady, because if we can prevent a fall, that's prevention number one, making sure that you're able to feel steady on your feet so you don't fall and then lead to a fracture. Kind of what goes along with that is making sure that you're getting your eye test, your eye exam every year, getting new glasses if needed. And also doing fall prevention at home. Take a look around your home. Do you have any rugs that are kind of curled over that you can trip over? Do you have any exposed cords that you can trip over? Do you need a handrail when you're coming out of the shower to prevent falls when it's slippery? So take a look at your home and get rid of any risks that can increase the risk for fall is very important. And then going along with that is have your primary care doctor review your medications. Are you on medications that promote confusion? Are you on medications that can cause dehydration and lead to fall? Do some of these doses need to be adjusted? So definitely do a medication reconciliation with your doctors to make sure that you're not on anything that can facilitate or increase the risk for making you feel unsteady or for causing falls. In terms of medications that we can give outside of the lifestyle changes, I'll go over these categories. There's three categories that we think of when prescribing medications for osteoporosis. The first class is called anti-resorptives. And the way these medications work is that they prevent bone breakdown. So they don't help to build new bones. They just prevent the bone from getting weaker, and they also make it stronger. And I'll go through each of one of these individually, but we have bisphosphonates in this class, Raloxifene and Denosumab. The second class of agents are called anabolic agents, and these medications actually help to build new bone. They're very effective, and the ones that we have in this class are teriparatide and abloparatide. And then the last category is a medication, a neuromedication that actually does both, called Evenity, and I'll go through each one individually. All right, so let's start with the anti-resorptive bisphosphonates. So these medications, again, work by inhibiting bone breakdown. They decrease loss of mineral and collagen in the bone as well. And they come in two forms. So either as a tablet that you can take once a week or once a month, depending on the medication, or as a once a year infusion on a medication that you would get through an IV once a year. And that's called zoledronic acid, or Reclass is the brand name for that. And these medications are very effective compared to patients that are not on any medications or placebo. They reduce risk for vertebral fractures by more than 40% and also reduce the risk for hip fracture by more than 40%. And the risk for any fracture by more than 15%. So very effective medications. Contraindications, reasons not to prescribe or take these types of medications are in patients that have any history of chronic kidney disease, where their filtration rate or the kidney filtration rate is under 35. That's a contraindication. And then I would also avoid the oral form of this medication in patients that have any underlying esophageal disease, or in patients who have gone for Roux-en-Y gastric bypass surgery. I would also avoid the oral formulation. In terms of side effects, so what are the adverse effects of being on these medications? For the oral formulation can worsen heartburn in patients or gastritis. So if you have heartburn, if you're taking a proton pump inhibitor, if you're on Pepcid, then it's probably not the best option because it can definitely worsen those symptoms. In terms of the IV formulation or the infusion, a side effect that's unique to the IV form is that it can cause an acute phase reaction, which basically means you feel like you have the flu after you get this medicine. So you may feel achy, feverish, you may have bone pain, and this, however, is usually transient. So it may happen a day after or a few days after the infusion, but generally goes away. And if you do develop those symptoms, you can definitely take a Tylenol to help. And this happens in about 10 to 20% of the patients may get this reaction, but with Tylenol, it's usually well tolerated. Rare side effects that are associated with both. So if you decide on the oral bisphosphonate or the IV infusion, these sound a little scary, but are very rare. One complication is called osteonecrosis of the jaw. And basically what that means is that you get erosion of the gum line and you can get exposure of the bone underneath it. It's very, very rare. It occurs in less than 1 per 100,000 patients that are on bisphosphonates. But the times we do see it are in patients who are getting these medications at higher doses or more frequently because of cancer therapy and not because of osteoporosis. And the other times we see this are if patients are on these medications and they're going for invasive dental procedures. Invasive meaning a tooth extraction or implant placement. If you're going for crown or cleaning, that doesn't increase the risk. And the last rare complication of bisphosphonates, the tablet or the infusion, is something called an atypical bone fracture, which is where you may fracture your femur bone without any trauma. And this typically presents with growing pain. This tends to happen in patients who have been on these medications for many, many years without stopping or without taking a break. So to prevent this from happening, we typically recommend being on the oral medication for 5 years and then we take a break. Or if you're on the infusion, we typically recommend starting treatment for 3 years. And then again, we take a break, we pause or holiday from the medicine to make sure that we're avoiding this risk factor. All right, the second class of antiresorptive is Denosumab, or the brand name of this medication is Prolia. And this medication is a monoclonal antibody that helps to prevent bone breakdown as well. It's an injection that you would get every 6 months subcutaneously, typically in the arm. And unlike the bisphosphonates, it's actually safe to use in chronic kidney disease. It's also very effective, decreases the risk for vertebral fracture by 60% and hip fracture by 39%. Adverse events, it can cause low calcium, it can increase the risk for infection, particularly cellulitis, and some patients may also get achiness after the medication is given. However, what's the most important thing to note about this medicine is that once you start it, I don't recommend stopping, or if you want to stop, I recommend starting another medicine, because if you stop it, you can actually increase your risk for fracture. So if you miss your dose or you stop the medicine, we actually see higher rates for fracture. So that's very, very important. Don't stop the medicine, or if you want to stop it, make sure your doctor switches you to a different one. All right. Raloxifene is another anti-resorptive. It's a estrogen receptor modulator. It binds to estrogen receptors in the bone and prevents bone breakdown. This is not as effective as the other medications we discussed. It really only prevents fracture in the spine by 36%, but doesn't really have any evidence that prevents fracture in the hip or in other areas. However, it can be considered in patients who have a history of breast cancer because it also helps to prevent recurrent breast cancer. And side effects associated with this medicine are that it can actually increase risk for clots, and it can also cause hot flashes. It can worsen postmenopausal symptoms. Next, we have the anabolic agents. So these medications actually build backbone, and there's two in the market. There's abloparatide and teriparatide, and these do stimulate bone production. They're very, very effective. Reduce vertebral fractures by more than 70%. However, contraindications would be if you have any history of metastatic bone cancer, history of osteosarcoma, if patients have had a history of radiation to the bone, and patients who are pregnant should avoid this medicine. It's usually very well tolerated, but can occasionally cause high calcium levels, dizziness, headache, and rash at the sites of the injection. And then the last medicine is Romosozumab, and this is a monoclonal antibody to sclerostin, and it helps to both inhibit bone breakdown and it also builds bone. So it works very, very well. It's only FDA approved, however, in postmenopausal women. It hasn't been approved in men. And it reduces vertebral wrist fracture by 73%, so very similar to the other medications we just discussed, and it can also increase your bone density by about 13%. However, what's important to note about this medicine is that although it's very effective, in one trial, patients on this medicine did have higher rates of cardiovascular events, meaning heart attack and stroke. So we do use this medication with caution because of that higher risk, and I would avoid it in any patient with underlying heart disease. And once you've picked a medication to start on, we would recommend repeating the bone density scan every 1 to 2 years to make sure things are stable or getting better. If things look like they're getting worse, then we may want to switch the medication and try something else. We also recommend monitoring your calcium and vitamin D levels. And if you're on the bisphosphonate, then we typically recommend stopping the medicine after a few years to make sure that we're avoiding atypical bone fractures. All right, these were my citations and references, and I'll exit chair so Dr. Smith can present.
Thank you.
Wait, what if we have questions for you? Can we ask?
What we said we were going to do is in the chat, you can put your questions. We already have a bunch of them from people. At the end of the presentation, we will open things up and we'll deal with both the questions that are in the chat and alternate with people who have questions that they didn't put in the chat. Okay. Cool.
Yes, thank you for that great presentation. Dr. Guzman and I not only work together now, but we train together, and what a great privilege it is to be presenting with her tonight. And thank you all, of course, for having me. So I am going to be presenting basically this condition called the overactive parathyroid gland. It's called hyperthyroidism in medical terms. And thank you for all the questions in the chat. And I am going to try to end with enough time to answer them all, hopefully as many as we can online. So thank you. Thanks for listening in. So the first thing I wanted to just clarify is what is the difference between a parathyroid and a thyroid? So the thyroid gland is what basically surrounds your windpipe, and it's like a butterfly shape right in front of the windpipe, which is called the trachea. So it's right here, if you can see my screen or my video. So it's going to be right here. So this is where we're feeling when we're feeling your thyroid. Now, the parathyroid glands are most commonly located right behind the thyroid. And as you can see, they're much smaller than the actual thyroid gland. But this is not the only place you can have them. So there can be various other locations that are completely normal, but it just varies from person to person. All right, so the epidemiology of primary hyperparathyroidism. So one of our physicians at Columbia, Dr. John Bilezikian, is actually kind of a world expert in this. And just 2 weekends ago, he presented new guidelines that were presented at the American Society of Bone and Mineral Research. So I'm going to try to include as much of the information that he presented there. However, a lot of it has not been published yet, so they're in the process of getting them out. So, but I am going to try to give you the most up-to-date information. All right, so what he noted was that this disease used to be one that you detected when people came in with symptoms. And the symptoms I will go over in a few slides, but basically our term for it is bone, stones, and groans, meaning bones is that you get a fracture from osteoporosis, which is what Dr. Guzman just talked to us about. Stones being kidney stones, which, you know, obviously a very painful event, and then groans, meaning that you're feeling overall fatigued, having some muscle pains. But now he's saying that our detection has gotten better in that we're now diagnosing it mostly from subtle differences in the labs that are often taken yearly on our annual physicals. Now, in terms of who gets these, you can see here that women are much more affected, about 4 times more affected than men are. In addition, about 10% of the reason why people will get get this condition are from genetic causes, but usually it is not necessary to do genetic testing. In fact, we will usually only do it in very young patients who develop it, or patients that have it in all 4 glands, so an overactivity of all 4 glands that are located behind the thyroid. So how is this diagnosed? Well, the most common type is when you have a slightly elevated calcium. And I was cheating a little bit, and I saw in the chat someone mentioned a slightly elevated calcium. But you can have a slightly elevated calcium, and in response, your parathyroid hormone should be low. But in this condition, your parathyroid is overactive, so it's not responding correctly, because it is the hormone that is responsible for increasing calcium. So when your calcium's already high, its proper response would to be low. So what we end up doing is we measure your kidney function, calcium, magnesium, phosphorus, and vitamin D level. And we usually try to confirm this high calcium about 2 weeks apart, two times. So here's a summary of what abnormalities we might find. So you can have a calcium that's very high, a phosphorus that can actually be low, and then a parathyroid hormone that's high. But again, as I mentioned, you can actually have a high calcium and a normal parathyroid gland. Now, things that we do have to rule out are other causes that could cause this lab abnormalities, which can actually be from vitamin D deficiency sometimes, or medication side effects. So keep in mind that these medications that I listed here, hydrochlorothiazide, Lasix, those are both blood pressure medicines, and they both work on the kidney. But their side effects is that hydrochlorothiazide can actually keep calcium in your body. And Lasix has a mechanism where it actually lets you let go of calcium through your urine. So it is important when we are interviewing, when I interview patients who are coming into me for this condition, I do take a very careful history of their medications. Another possibility that can cause a high calcium is very high doses of vitamin D or vitamin A. So if you're on, supplements other than the ones, or at higher doses definitely than the ones that Dr. Guzman just talked about, then that can also cause a high calcium. And in those scenarios, I ask the patient to stop the vitamin D and we recheck the labs in about 1 to 2 months. Now, when you wake up in the morning, what would make you think that you have a high calcium? Well, one is that you might feel really tired, and you can also feel pretty confused too. Initially, people that get this condition will have a high blood pressure, but eventually that might become a low blood pressure. And it is due to the next 2 bullets I have here, drinking excessively and urinating excessively, because that is your body's way of diluting the calcium. It basically, your body needs water so it can wash out the calcium through your kidneys. So that is why you might find yourself drinking excessively of water and urinating excessively. Another issue that people notice is that you can have body aches as well, so muscle aches. Now remember, Dr. Guzman made a good point of this in her presentation. Osteoporosis itself will not hurt unless you develop a fracture. And even at that, she was mentioning that with the vertebral fractures, sometimes people don't even have pain with that. All right, so once we've established the diagnoses, it is actually, according to these new guidelines, going to be recommended that once you are diagnosed with this condition, to go ahead and get a bone density scan that Dr. Guzman was mentioning. And the reason is because it's good to have a baseline to know what your T-score is before this condition is treated. And also, it's a good idea to have vertebral imaging. What does that mean? That means an X-ray of your spine. So just like she was suggesting to do it to rule out a vertebral fracture, we also recommend it upon the diagnosis of hyperparathyroidism, or an overactive parathyroid disease. Another thing that's usually evaluated by this point at any case, but is recommending to review the kidney function, because over the years, when your kidney has been clearing out all this calcium, eventually it can get tired out and you can have a decrease in your kidney function. And then imaging for kidney stones, that would be an ultrasound of your kidney, should be performed in these patients. One thing that is a little bit different in the osteoporosis that Dr. Guzman was talking about versus the osteoporosis that I am talking about is that in parathyroid overactivity induced osteoporosis, actually more so the wrist is involved. So the very end of your forearm is actually the most affected bone with an overactive parathyroid disease. So sometimes we do use that to help us guide to see whether a person is being affected by an overactive parathyroid gland. Because again, the postmenopausal and the age-related osteoporosis will affect more the spine and the hip, whereas the parathyroid will affect the wrist bones the most. In terms of treatment, well, there is a surgery, and that is actually our #1 recommendation, especially if somebody is younger than 50, if their calcium has actually been found to be a whole point above normal, if they already have a fracture, if they have that low bone mineral density, a T-score less than negative 2.5 that Dr. Guzman was talking about, renal chronic kidney disease, or kidney stones. Those people especially are going to be recommended to do surgery. Now, at Columbia, we do have a thyroid and a parathyroid center. And at these centers, the surgical cure is very effective, and you can actually expect a very significant reduction in that fracture risk. Now, some people wonder, how big will the scar be? It's not big at all. It is actually very well hidden in most people's natural creases. So these are pictures from patients who went to our parathyroid center and had this surgery. So as you can see, it's very well hidden in the natural crease. And and usually the patients are either an outpatient, meaning they go in and out the same day, or they stay maybe one night. Okay, so this surgery is usually very well tolerated. Now, let's say you do not want a surgery, or you do not feel, or the physician does not feel as though you'd be an appropriate candidate for surgery. You can still, according to the new guidelines, use bisphosphonates, which is what Dr. Guzman was talking about, with the goal being to reduce fractures, vitamin D supplementation, or a medicine called cinacalcet. I will say, though, that none of these are going to be as good as having the surgery. So these are definitely second line in terms of what would be the best treatment for this condition. Now, what are the risks? So whenever we talk about a procedure, we do always talk about the risks. So one is that you can have a temporary or a permanent issue with too much of your parathyroid gland being taken out. Luckily at our center, temporary low calcium is only 5% and permanent only in less than 1% of people that get this surgery. Bleeding less than 1%, and there are two nerves that run behind the thyroid. Again, going back to that picture that I showed you, that is near where the parathyroid glands are. But luckily, in the hands of very experienced surgeons, you can have only very low risk percentages, with a temporary hoarseness being about 3% and permanent being less than 1% at our facility. And again, the definition of this, and I definitely made a point to capitalize this, so this is the opposite problem of what we were talking about, is again when more parathyroid tissue is removed, so HYPOparathyroidism. And the guidelines are actually going to state to go ahead and measure a parathyroid hormone level very soon after surgery, 12 to 24 hours. And so if you do develop this condition, then there are certain algorithms that we do use to make sure that the patient is treated well with calcium supplements, vitamin D, and in some situations, hydrochlorothiazide. And in some cases, low phosphorus diet can also be useful in these patients. All right, well, I did want to make sure that we had enough time for the questions. So I will go ahead and I guess, should I just start going through the chat questions, or? Okay, I'll go ahead. All right. Okay, so one of the questions is, how do you treat a vertebral fracture? So on our end, and I'll let Dr. Guzman chime in if she has anything to add, so with vertebral fractures, as soon as we do recognize them and detect them, we do refer to orthopedic surgery. And at that point, they will decide whether it is just a brace that you need, whether they do recommend a surgery, or again, maybe just like a back brace. So again, it's either going to be surgery or it's going to be conservative management.
So I think what we'll do is we'll do maybe like 3 questions from the chat, and then we'll open it up and see if anyone has a question, and then we'll alternate, because I just want to be fair to people who didn't put questions in the chat as well.
Sure. That's
so the next question was a slight elevation of blood Ca, which I assume is calcium, but I have osteopenia, what to do? Now, one thing I would say, just for the doctor's sake, is that they don't have access to all your medical records to know everything about you. So some of these questions where people are asking for recommendations on what medicine to take, you may not feel as comfortable answering.
Yeah, so for this case, I would recommend actually doing further evaluation, because the slight elevation in calcium, like Dr. Smith was explaining, could be a sign of another underlying issue like hyperparathyroidism. And oftentimes, if you treat that underlying issue, the osteopenia should get better. So I would recommend getting that worked up to make sure that there's no other underlying condition that's causing the high calcium that can be treated, and that can help to protect the bones further.
The next question is, and again, I'm just going to say things incorrectly. Where is strontium? Is that correctly said? Found?
Yes, the strontium can be sold in over-the-counter supplements. So take a look at the supplements that you're buying for bone health, for osteoporosis support, and take a look at the back. If you see strontium on the list, don't buy it.
So now I'm just going to switch over. Are there any questions from people who want to open up their Zoom and ask any question? If not, we'll go back to the.
Excuse me, I have a question.
Sure, right.
Real quick. This lecture is going to be on. It was filmed, right?
Yes, it is. Yeah.
Is there a website that we can go to if we want to look?
It'll be on our YouTube. It'll be on our YouTube site, and you can get to our YouTube site just by going to rssny.org, and there's a link right there. So it'll probably be up sometime tomorrow.
Okay, thank you.
Sure. Any other questions?
Yes, I have a question.
Okay.
My doctor, I have osteopenia, and my doctor recommended Forteo.
Kale? Do either one of the doctors want to jump in?
Yes, so Forteo is a medication that's part of the anabolic category, so it helps to build back bone. It works very, very well, specifically at preventing fractures in the spine. However, it is a medication that's only FDA approved for 2 years therapy. So be aware of that, and it's a daily injection that you have to self-administer to yourself, but it's very, very effective at preventing fractures.
Right, because I had several fractures. That's why she suggested Forteo. All right, thank you very much.
That would be a good
Sure.
option. Mhm.
Now we'll go to the chat. Is vitamin D3 good as a supplement?
Yes, vitamin D3 is excellent. So there's 2 vitamin Ds. There's vitamin D2, which typically your doctor will prescribe if you have very, very low vitamin D levels under 15. And then vitamin D3, that can be bought over the counter. And taking about 1,000 international units per day is helpful to maintaining levels above goal, which is above 30.
Another
Hi.
question, let me just go to another question from the chat. My
Okay.
doctor recommended Forteo. What is your opinion?
Oh, that was me.
Okay,
Never
oh, so
mind.
then,
I
okay,
got the answer. Thank you.
okay.
Hi,
Another person, can you just wait for 1 second? We'll deal with another question, and then I don't know your name because it just says Zoom user. We'll come back to you.
Oh, all right.
Okay, I had breast cancer and take IRIMIDX, which has an adverse effect on bones. I also have osteoporosis. Which medication makes most sense for me?
Yes, so that medication that you're on, it's helpful for preventing recurrence of the breast cancer. So definitely continue to take it as per your oncologist, but it definitely can increase the risk for further weakening of the bones. So I would recommend, if you meet criteria, either getting treated with a bisphosphonate, like the IV reclass, or the Prolia, which is the every 6-month injection.
And then 2 questions that are kind of the same, and then we'll go to the Zoom user. Is taking raw calcium better than calcium citrate or carbonate?
So definitely getting calcium naturally from the diet is preferred to the supplements, because you absorb more of it from food than you do from the supplementation. So definitely diet is better than supplements if you're able to get the 1,200 milligrams through your diet.
And then I'd be interested in hearing about other alternatives besides pharmaceuticals. Is there anything else besides diet?
Right. Aside from the lifestyle changes that we discussed, making sure your calcium is replete, your vitamin D, the weight bearing exercises, and the fall prevention, there are no other natural therapies.
Okay, so I'll turn it over to the person where it said Zoom user. Also, if you can identify yourself.
Dorothy
would be helpful.
Petrolati.
Dorothy. Hi.
Petrolati.
Hi, Doctor.
How are you? The spine specialist here told me I have degenerative disc disease, and four years ago, lifted furniture, and that's when the trouble started. But I've been doing acupuncture and different things. I was wondering, do I need anything to do? I don't take any medication. I take supplements, D3, calcium at night, but I also eat pretty good, the Mediterranean diet. And I was just wondering, degenerative disc disease of the spine, is that also in the osteoporosis element?
Yeah, so that's a good question. So degenerative joint disease is more of an indication of arthritis. So
Yeah.
basically with time, let's say this is your spine, your vertebrae, over time, that space starts to go away. And you get kind of bone on bone contact that can cause pain, but it's different than osteoporosis. So I would, however, recommend if you're over 65, definitely getting a bone density scan to assess for osteoporosis, because if you do have it, then you can get treated.
And yeah, that's what I did. I'm gonna see the spine to see what it entailed, but I don't take Medicaid. Thank God.
Okay.
They wanted me to do spine surgery. I said, no, thanks.
Okay, Dorothy, I'm sorry, we're gonna have to, we just have a limited amount of time, so I want to get to all of these questions. The next is, if I am on, I could definitely, my father was a pharmacist, but I can't pronounce anything. If I am on hydrochlorothiazide, should my doctor be keeping a close watch on my calcium numbers?
Yeah, that's a good question. So yeah, hydrochlorothiazide. So yeah, I mean, usually the kidney should be able to compensate. But for instance, if you're taking hydrochlorothiazide and in addition you have this condition of an overactive parathyroid gland that's also increasing the calcium, then those two together could potentially monitor the calcium. But absolutely, I mean, your primary care who has you on hydrochlorothiazide, they are likely checking your kidney function and calcium every time you're seeing them. So yeah, I would say yes, they should, because that is one of the known side effects.
What are vitamin D metabolites?
That's a good question. So vitamin D, when we are looking at causes of a high calcium, we do actually get one lab that is a vitamin D metabolite. It is, so the usual vitamin D level that you get is called 25 OH. Metabolites are 120, like one that we get frequently is 125 OH. And what that means is it's a more active form of vitamin D. And unfortunately, what happens in an overactive parathyroid gland is your parathyroid, because it's overactive, it actually takes the regular vitamin D and it shunts it over to a very active form of vitamin D. So you might actually see that your vitamin D level is low or normal, but then your 125 is very high. That is a common, it's a common lab abnormality that we see.
Again, I'm just butcher words. Is ALENDRONATE the generic form of Fosamax?
Yes, so alendronic acid is the generic Fosamax.
Okay, and then the next one, I don't know if you can see this, but what does subchondrial sclerosis in bilateral femoral heads, likely chronic vascular necrosis means? They speak a different language in my chart.
So vascular necrosis basically means that you're not getting enough blood flow to that particular part of the bone. That can actually increase the risk for fracture as well. It's a separate entity from osteoporosis, but it can increase risk for fracture as well. That's usually managed or treated by an orthopedic doctor.
There is, what about estrogen treatment for osteoporosis?
So we discussed a little bit about the Raloxifene, which is a selective estrogen receptor modulator. In terms of estrogen treatment itself, it's not part of the treatment guidelines that we use, but it can be considered in patients who are postmenopausal, who have other symptoms associated with menopause. And also you can consider it if the patient's within 10 years of having menopause. I would not recommend it if you're more than 10 years out from menopause, because it can actually increase the risk for clotting and other events. So not recommended if you're more than 10 years out.
There's one more question in the chat, and then we're going to close off any more questions in the chat, so don't put anything else in the chat. There is a supplement called raw calcium made from algae. Is that form better?
It's right here. Have it
Yeah,
there.
I'm
So,
not familiar.
there are different brands that use calcium made from algae. I would suggest just taking a look at the back of the bottle, because it's usually either calcium carbonate or calcium citrate. It's derived from one of those two. So just take a look at the back to see exactly what type of calcium it is.
No, it says algae. It says derived from algae. It says it's derived from algae.
So the calcium itself is from the algae, but it has to be either the calcium citrate component or the calcium carbonate component for you to absorb it.
She's saying, look at the details on the back. I'm gonna, while you're doing that, I'm gonna see if anybody else has any other questions for the doctors, because we're almost at 7 o'clock. I want to be cognizant of everyone's time, and everyone's probably hungry for dinner. Are there any other questions?
Yeah,
Whoa,
just
whoa,
me.
whoa, 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 everyone's talking. at the same time.
Apologize. I apologize.
That's okay. Marcia, do you have a question?
Yes, I'm confused.
Okay.
I take 2 different vitamin D3. One is 125 mcg and the other one is 2000 IU. My doctor said I was taking too much of the 125 mg. She makes me switch every few days. Am I right? Is she right?
It all depends on your levels. So it depends on what your vitamin D level is and how much you require. So
Well,
it's hard to say.
I've already fractured and I've already had reclass, but this is confusing to me. So I guess whatever she's doing doesn't sound wrong. Okay, because she didn't give me good answers.
Well, so 25 micrograms is 1,000 units. 50 micrograms is 2,000 units. It's just a different dose, like a way of saying what the dose is.
She was afraid I was taking too much and I would get into trouble because I fractured myself just walking. So it's, it's just a matter of trying to be careful now. Okay.
Are there any other questions?
Yes.
Sure. Who is that?
That's Maria.
Oh, okay.
Maria. Hi. I had an accident and I fractured a couple of ribs a while back, and I'm not really sure what the difference is between a fracture from osteoporosis and something like if you fall and you hurt yourself. Is there I was never diagnosed for osteoporosis. Nobody ever said, my doctor never said I had it. But I'm just wondering if you have to go to a doctor and have that analyzed.
So yeah, because you did have a few fractures, even in the setting of trauma, I would recommend getting a bone density scan. If you would have had these fractures in the absence of trauma, so if you had a fall while you were sitting, then that actually counts as a fragility fracture and is a basic indication that you do have osteoporosis. So I would recommend getting a bone density scan since you did have several fractures.
Okay, thank you.
Anything else? Because I'm going to then thank the
Yeah,
doctors.
I have a question.
Okay.
What about, there's been some new studies done on vibration exercises for osteoporosis and increasing bone density?
So I actually haven't taken a look at those specific studies, but I would just caution, depending on how significant the vibration is, you don't want too much movement if you have spinal osteoporosis, because you can fracture from a little bit of impact. But I'll take a look at those studies that you mentioned.
Yeah, there was an Italian study and then just a US study.
Thank you.
Okay, I think unless there's anything else.
I just have one question
Okay.
about spinal stenosis and how does that factor? Does that normally go into osteoporosis later in life?
So that's a good question. Spinal stenosis is a separate entity. It basically means that you have narrowing of your spinal canal, and it can cause basically nerve pain because it's being compressed. But that's separate from osteoporosis because it's compressing the nerves, not so much the bone.
So I want to thank both doctors, Dr. Guzman and Dr. Smith. This is a wonderful presentation. We had about 50 people come, so there was a lot of interest, and it's really important for all of us as women over 50 to be very cognizant of this. And I personally had to do it. I really would encourage, if you haven't had a bone density test, you definitely should get it. It's very enlightening, good and bad. So thank you again. Thank you for taking time during the evening, because I'm sure you've been working all day and now you work tonight too. So thank you. I'm going to, I guess, end it for everyone, and everyone should go have dinner if you haven't had dinner. Okay.
All right, thank you.
Thank you so much. Thank you so much,
you.
doctors.
Thank
you,
you.
Dr. Smith. Okay.
Thank
Take
you.
care.
Thank you.
Everybody take care.
Everyone.
Bye-bye.
Thanks, doctors,
Bye.
everybody.
Bye-bye.